how the course page works in the Moodle unit. So here's some content. So this is your free CPD bit. So looking at then this paediatric series, what set it all off was that you know, there are lots of conditions that osteopaths deal with, and certainly, for example, in infants, there are, you know, people have problems with suckling and sleeping, and then their sense of self. I went on a bit about the number of S's, but essentially all of these things, suckling, settling, sleep, sentiment, shape, moldedness, are all my premises to do with sensory experiencing. So it's a sensory dynamic. So the S that relates to babies that present with suckling, sleeping, unsettledness, and so on disorders is not the sphenoid S, but it's a sensory S. So you have to explore all sorts of sensory dynamics. And so when we look initially at the intrauterine environment and the space issues, we understand a lot about the sensory relationships and experiencing between the two. So it's not just a physical fit, it's a mutual exploration of bodies and self. And so how the baby develops its sense of itself, its sense of either fear or awkwardness, or its sense of comfort and ease, all of those things are developing in this intrauterine period. And so it will carry the infant from its intrauterine experiences, yes, through the birth, but also the that issue of its sense of self and who it thinks it is and what sort of deal it thinks it's been dealt with so far, and whether it's happy and integrated or whether it's stressed, fearful, under a threat response, and so on. Etc. So there's a few dynamics there that we need to talk about. So I do like the Merleau-Ponty dynamic of the maternal-fetal relationships to help us understand that. But it's in this context of space and exploration and physically reaching out and so on, and getting feedback back that we talk about in module 1, for example, we get this understanding of how the proximity, tightness and tension of the membranes are a thing that the baby can interact with. And we forget to realize actually how tightly bounded one is by one's membranes. They're quite elastic, and actually this tension feeding back in onto the infant gives a lot of sensory information through, and so that's obviously one of the reasons why swaddling is calming, why ultimately joint squishes and compressions for older people who are unsettled, older children, is good, because in the intrauterine calm parasympathetically dominant environment where the autonomics is hopefully stable, then this physical pressure is related to a certain type of autonomic physiological functioning, so a certain state of function. And so we go through all the time how literally it's this sensory experiencing, the physicality of it, both from outside onto the body, but from within the infant's body, sets up the autonomics. We also obviously talk about the intrauterine moulding dynamics, and so how actually the babies become sort of bent and twisted and how the bones form. And we talk a lot about, you know, where important bones form first, here, not here. But we talk about intraosseous strain, and as I say, I don't do involuntary mechanism versions of stuff, but I do my own gentle versions of intraosseous unwinding, ultimately sutural gapping, globally orienting the overall membranous dural dynamics, looking at circulation within, looking at fluid movements, drainage, CSF. I look at all of that, but I don't just have in my head the involuntary mechanism. I don't have that at all. I have other perspectives in this physiological activity and vitalistic dynamics. And so for me, that primary respiration is definitely the activity. It's the expression of the physiology and its effectiveness and this integration, rather than it being something other than that. But anyway, so we talk about bones, and then we talk about how you give birth. So how do you get head and the body through the pelvis? What impact does that have on the baby? So we talk a lot about the birth process and how the whole birth is organised, what initial primitive reflexes help guide you through the birth canal, but also about the physicality of the whole baby being birthed, and so the stress on all the parts of the infant. So we don't just focus on the head and the overlapping, we focus on how the head, neck, shoulder interface is, how the body torso is affected, what happens with the pressure onto the pelvis from the top of the uterus, on the presumption that you're going down head first, for example. So we talk a lot about that, and we do talk in detail about overlapping, what should overlap, how the skull is designed for that, what are these cerebro circulatory and fluid mechanic dynamics of moulding and the head release. So we can talk a lot about the mechanisms of injury, what is overlapping, and what impact does it have. And then we obviously can talk about all sorts of newborn warning sounds, and we talk about, you know, tone and posture, eye contact, responses to sound, behavioural changes, and we do quite a lot of interpreting the movement dynamics as to how that relates to their physiology underneath, and then if there's anything risky that we need to be aware of. Certainly we can start talking about, from this reflex dynamic of birth, the impact of, if you have not a good expression of initial primitive reflexes such as rooting and so on, that can really disturb your feeding and so on. And we ultimately will be talking about things that can impact on these reflex expressions, but that all comes a little bit later. And so initially what we're looking at in the birth strain is the mechanical dynamics onto the head or body, the possibilities for stress strain and the implications for circulation, and then the dynamics about how in fact your sagittal sinus is different in the infant, how it makes use of its emissary veins and long bridging veins, for example, and how as you're moving you can actually have a different perspective on the head, perhaps as the head is a fascial compartment, in the sense that you can mobilize, dynamize, and work very gently and have respect to possible risk factors and so on. And you can do that from a non-involuntary mechanism perspective. You can take a three-dimensional movement, making use of the spaces, gaps, and so on, etc. So we do go through quite a bit about exploring sutures, exploring fontanelles, what it all means, how you can do it, etc. And then we obviously a little bit of routines. And this is all just essentially at the end of module 2 and module 3. Then we talk about the transition physiology, and we talk about maturity, and we talk about, you know, how old do you have to be before you can be born and survive, and what help do you need. And in this day and age where lots of babies are born even just say 1 or 2 weeks early with elective cesareans, for example, then many babies are emerging with a different arena of maturity within, and also based on their intrauterine environment, that maturity may be impacted by all sorts of things. So when you evaluate the vasosteopaths, you're evaluating different nervous systems that don't all have an equivalent set of functionings. And so it's really important that one understands the transition physiology and this dynamic of the circulation, the dynamic of the heart rate, the dynamic of respiration, and the alertness, and so how the autonomics are balancing all of that side of stuff, because it's this level of transition stress which can then lead to behavioural responses, changes and adaptations in the infant. And actually what you're seeing as an unsettled infant isn't because they've got a pain from their, you know, stressed clavicle, for example, per se. It's about how their autonomics aren't being able to stabilise their internal environment. And as we see in later modules, yes, of course, that pain may be contributing to a disordered autonomic state, but that is what it's doing. It's disorganizing the autonomics such that then there is an autonomic disturbance of motor tone stability, for example. And so the issue of the clavicle isn't that it's a biomechanical torsion, it's a sensorially nociceptive and autonomic disturbing dynamic. But anyway, that's getting ahead of ourselves because we pick all of that up in later modules. But what we also have to consider is this relationship between mother and child, and how the skin to skin, the maternal contact, the maternal status impacts absolutely directly on the infant status. And so definitely we pick all of that up again, of course, in the later modules to do with infant feeding, infant sleeping and all that sort of stuff. But we also talk quite a bit about respiratory dynamics and the first breath and clearing the lungs, and we talk about the impact of different birth processes, so that we understand that actually the movement and the organisms and therefore the tension patterns that we feel are actually the infant's status and organisation around whether they've got their suck, swallow, breathe organised, whether their cardiorespiratory centre, whether their vagal tone, etc., is all managing this stabilisation of blood pressure, circulation, tissue perfusion, ventilatory rate, and then levels of arousal in the infant. And all of that then relates to this interoceptive dynamic of the neonate. And so because the somatic nervous system is much less developed than the visceral internal autonomic nervous system, interoception is more informative within the neonate environment than is somatic information. So we talk about that. So we also talk quite a bit about the state of your states. So your autonomic system state, your visceral state, your motor state, but also your state of consciousness or levels of alertness and arousal. And so we talk quite a bit about those, the implications for observations, the understanding of what to consider in practice, and to see if the infant is stable or unstable and so on. We then initially begin to bring in this whole idea of the autonomics, the stability of posture, the suck, swallow, breathe. And so we introduce something here now, which then we take up again on the later module. So it's rhythmicity, and it's the autonomic integration of complex movements. And it's often the infants struggle with the latching because they can't manage arousal, they can't manage physiological state regulation, and those two things lead to both emotional stress and motor distress. So they start to, break off, pull off the nipple, can't maintain a suck, all this sort of stuff. And there's nothing necessarily wrong with their somatic structure. Even if you can feel tensions, those aren't necessarily etiological, but they are in fact direct outcomes of this disorganized, disordered state. So yeah, there's lots to unpick when we go through that. And of course, we continue to work on this dynamic of the two polyvagal theory participants, the mother and the baby, the role of oxytocin and the behavioural readiness for all sorts of things to do with infant communication. But we also essentially make up this idea about posture, the position of the infant, its movement dynamics, this organisation into flexion and the midline and so on, and how that relates to physiology. And we talk about how if the infant starts to move, even just a small movement disorganises their autonomics temporarily, and they have to resolve that. So that there's this idea of movement as it's emerging, as it becomes developing, as the infant is trying to do more with it, it has to do so at a rate that relates to the autonomic efficiency that goes along with increasing movement and metabolic demands. And as you begin to move, of course, you get kinesthetic sensory feedback as well as interoceptive feedback, but you begin to get balance and vestibular dynamics. And so then when we get into the later modules, we talk about vestibular integration, we talk about vision, and we talk about obviously hearing, and how all of these balance mechanisms have to be developed, and how balance and orthostatic tone and autonomic responsiveness also comes into that. And then we begin to introduce the concept that of course pain impacts on all of this maturation process, and how pain impacts on this neural networking and therefore the development of movement efficiency and coordination. So we set it up that the motor stability and efficiency can only be on top of a stable physiological base, and that if you do experience pain, it disrupts this. So then, of course, we go through this idea of infant states of consciousness. What are they? When should you feed your infant? And so on. And we look at sleep and unsettledness. And we look at thermoregulation, we look at posturing in sleep, we look at, we mentioned a whole number of stuff, but we do have to understand about the dynamic nature of sleep. And what about prone sleeping, what about supine sleeping, what does it do? As the infant wakes itself up and goes itself back to sleep, if it stirs, does it need to be interrupted by someone coming along and doing something to it, or is this sleep patterning going along? But we talk about oxidative stress and sleep, and again we set it up here for later modules. We also obviously continue to work on this visual cues, and then how mum's sensitivity to, as she's observing her infant, can she then interpret the infant cues? Because of course if you can interpret infant cues and act on them, then you contribute to the infant's sense of safety and security, and therefore autonomic and eventually motor stability. And so the status of mum is really important. So this link between her ability to actually move beyond perhaps her stress and distress and trauma and, whatever. It's how that can then impact on the baby. So many occasions, babies abort with seemingly, suckling, sleeping or crying disorders. And actually, they're fine. They're doing a perfectly normal and perfectly expected response to the fact that the maternal caregiving practices have become strained and are not as effective as the infant needs. So the two aren't responsive to each other in the appropriate way. So we do talk a lot about all of that sort of stuff in the modules, and of course that links absolutely through to the social engagement system. It looks through to the bonding dynamics, and it also looks at the issues of, are you now in a does the infant think it's in a threatened and insecure dynamic? Because if it is, it's going to respond by having poor autonomic, so poor digestion, poor breathing rate, inability to sleep, can't self-settle, moves a bit awkwardly, doesn't like settling onto the breast. So all those things that are presenting are or can be interpreted in a lens of fear, threat, and inappropriate physiological autonomic status for the activity at hand. And that even extends then to your middle ear muscles, the arousal, the threat by auditory stimuli, being disturbed by other things around in the room, and so on. And we talk how all of these little insults throughout the body can accumulate, and we talk about how osteopaths use this idea of allostasis and increasing burdening to lead to a combined set of disorders, so that we can then actually arguably treat those as a state disorder influenced by somatic and nociceptive dynamics and circulatory drainage and fluid dynamics, for example, but that we understand them in the context of the whole infant, and the fact that these conditions are interrelated. So we don't say that reflux is different to sleeping, is different to fussiness, is different to plagiocephaly, so you don't necessarily need a separate treatment plan for all of them, because as we begin to explore in the modules, I'm going to try to get you to understand how, in fact, they're all part of, in many instances, the same sort of syndrome and disorder. So having this infant unsettledness as understanding it as a complex adaptive system response between the mother and infant can be a very valuable thing to take on board. Then, of course, we do have to understand some more impacts of infant pain and how pain disturbs everything. But how do you tell if a child is in pain? What do you watch for? They can't then say, oh, it hurts here. So you have to actually look at how to observe and look for infant cueings for pain responses. And so that pain and adapted sensation are the two things that then seem to be at the root of every PEDS problem that we see. So this concept of us generally working through the whole infant, reducing stress, distress, aberrant sensory information throughout the infant without worrying if it's got a direct anatomical knee bone connected to the hip bone type connection through central structures. What it does is it's working on the allostatic load, movement freedom, and the sensory experiencing, and therefore the sense of self of the infant, etc. We work on it from that perspective. And the aim, of course, is to reduce pain and to stop pains becoming embedded and chronic, because if you learn pain behaviours in an immature neonatal, newborn and young toddler environment, of course, then you grow a pain behavioured nervous system, and then you never have a normal nervous system, which then becomes affected and leads to pain perception differences and so on, and pain behaviour differences. You start your entire life, and everything thereafter is predicated by you having now a differently neurally networked dynamic based on early pain experiencing. So yeah, so we do talk about that, and we do talk about what to look for about the eyes and the fingers and the so on, as to understanding about crying and do you treat, don't you treat, do you stop, do you carry on, all of those things. And we talk about, facial expressions and what's going on. And then we talk absolutely about this trigeminal and vagal convergence. And we make the argument that actually huge amounts of vagal autonomic disturbance are coming from this trigeminal system, which, yes, has impacts from the social engagement dynamics, but the trigeminally innervated head and face is a really important thing to focus on. And so again, I make an argument about not necessarily wanting to concentrate here, but actually wanting to concentrate here. And engaging and talking to that trigeminal system of the infant so that it can then directly feed back through the extensive trigeminal nuclei network and the links that those parts then have onwards about all of the vestibular dynamics, all of the vagal autonomic control dynamics, and then we build in this concept of periosteal sensory innervation, but we also build in, myodural bridges, infratentorial space dynamics, and then the intraosseous perspective. And so I've just borrowed a couple of pictures from a Jane Carrero book here, but literally when you're looking at movement possibilities in the tissues, between the tissues, on the tissues, with the tissues surrounding these bones, the fluids within and all the rest of it, how we can pull all that together in a physiological understanding, such that when we say things like, oh, infant colic, work on the jugular foramen for the vagus, we can actually understand that far better, because in fact the jugular foramen isn't really just for the vagus, it's actually primarily for the jugular venous drainage and some other nerves and so on. So I want you to have an expanded fluidic model view of not only just the cranium but the jugular foramen, so that you never again say that, oh, colic, it's the vagus, it's therefore the jugular foramen, and that's the bit I need to work on. So the picture is much bigger than that. So we go through all of those, and then finally we come to the whole breastfeeding latch story, and we talk about mother's production, and then infants' predication to suck on anything, given half the chance and given the sensory willingness to do so. And we talk about, bits to do with nipples and ducts. And we talk about, things that you can do for mum and so on. And we talk about types of how latch is, what a latch score is, for example, what you need to look at. So as you're beginning to observe these things, you begin to realize that this is a really complicated story, and that actually that's why lactation consultants take a very long time to complete their training beyond, for example, being a midwife. And so this additional skill set is really, there's a lot to it, but I think at least that we need as osteopaths to be familiar, because we can, I think, engage on some level, especially if we learn to work in an interprofessional dynamic, we can begin to extend that. But we certainly need to understand what's going on, where our role is, what our place is. We need to understand how suckling does or doesn't move the cranium. And there's this assumption that if you have a good suck, it mobilizes the cranium through pressure on the palate to the voma. And I'm going to go through all sorts of reasons why that it doesn't work like that at all. It does help the cranium, but not through this link. So that'll be explored a lot as well. We look at the infant tongue, we look at the infant pharynx, we look at airways, we look at eustachian tubes and the suck, swallow, breathe dynamics. We look at respiratory dynamics within that, and we understand a lot more about where you suck from, which muscles to work on. And again, it's all about here, not here, for example. And we also then touch on the issues of tongue tie, tongue placement, and of course that helps us to understand why infants struggle. But because feeding is a sensorial environment driven by, let me scroll back up, the trigeminal sensory information, it's the experience of either the nipple or the tongue or the bottle teat in the oral cavity that then feeds back, works through the trigeminal system, works out then to give an efferent response, to give a motor pattern coordination. And so we remind you about the sensory experiencing, and such that even if tongue-tied children have their snip done, they will have up to that point, yes, they will have struggled to do it, but they will have had imprinted in a sensory experiencing and then a related motor patterning efferent component. They will have already had that built in. And so actually, when they have a snip, they aren't necessarily then able to automatically just do it differently. Just because it can move up, how does the infant know to try to move it up now? You have to have some sort of rehabilitation and training and re-engagement to provide and try to encourage a different sensory experiencing of the oral cavity and myofascial structuring, so that then that different new sensory information can be passed back in centrally, and therefore a re-coordination of other motor structures to come out, so that the actual suck action is different. So there's all sorts of things that we can get into and that you can work on and do. And then obviously we work on supporting that with respiratory work or digestive work, or all sorts of other things, and we talk about techniques and relative sizes and so on. And eventually we do then certainly get into this idea of baby visceral, and we talk about the development of the GI tract, and we talk about the villi and the gut circulation, which has a few curiosities. But we also talk about other organs such as the liver and the biliary system, and how the dynamics of that need to work. And we also then understand about the peristaltic actions throughout the enteric nervous system and the pacemakers and rhythmicities. So you have gastrocolic reflexes, and if you activate those, then the infant will respond and want to sort of poo or fart as they're actually having a feed, so they might break off momentarily. But it's not because something's gone wrong, it's because they're reacting to a gastrocolic reflex, which is causing the colon to evacuate or be more active as the baby's having gastric sort of filling through the feeding. So we talk about things like that, and we continue to talk about reflexes. But we then begin to set up this idea about the gut, the immunity, the microbiome, and how this then can impact onto central nervous system. We also then start to set up again and remind about ears, eustachian tubes and so on. And we make the case that actually a lot of the moulded baby syndromes, which we also then talk about, are to do with the contents, the cavities, the eyes, the oral spaces, the pharyngeal spaces, the ear spaces, and it's not just where the flatness is. And so, yes, we talk about management of these asymmetries and so on, but it's all about then how does it impact things on the inside. And so we begin to put all sorts of threads together at this stage, but we talk about the fact that actually many babies have a moulded baby syndrome, and it's not just plagioccephaly because they've lain on their back too much. There can be this issue of all sorts of things going on through the whole infant. Also, then we can talk about hips, and we can talk about how those things are normally managed, and then gradually we can talk about, you know, movement possibilities, how you walk yourself out or move yourself out of plagioccephaly, how you move yourself into a better hip orientation. And it really makes us really interpret how motor tone, torso shape, head shape, and symmetry of movement exploration then begins to bring about a coordinated hierarchical development of the infant. And we talk about all sorts of things ranging from, you know, all sorts of other types of mouldings, such as, you know, age and gender issues and infant scoliosis. And is it the dural tube? Yep, you have to wait and see as to what my answer is on that. Yeah, so ultimately, finally, we then get into what are all these developmental landmarks, but we understand that they have to meet their landmark development, not just in the motor movements, but in their sensory experiencing, their ability for language, their ability for socializing, sharing and playing, and the interactions with others and so on. So there's actually quite a bit if you're thinking about case histories and how you have one. And people always ask how many, you know, what's in a pediatric case history? And this is, well, it depends on the age of the child, because all your prompt questions are entirely different as to whether it's 3 months, 3 years, or 13 years. And so you can't have one case history. And so many times I see sports injuries, strain of teenage girls' histories, for example, being taken on a case history sheet, which still includes questions about the birth and so on, which at this point are not the most relevant questions to actually ask. So not all pediatric questions last the test of time across the child's emergent lifespan. So you're going to have to write a few, and we give you guidance on what you need to include for age-specific bits and bobs. But we do absolutely at this stage, but as you start to move and as you start to use your muscles, you actually start to pull on your bones more. And it's critically important that you realise this dynamic between action, intention, movement, and osseous perception, and then bony development. So we talk a lot about bones and how when we can then work on them, and we introduce this concept that baby's muscular system is actually using feedback from within the bone as well, so that you don't just have to work on the myofascial dynamics, you can actually work into the bones again in a whole variety of ways. And we talk about growth plates, and we talk about ossification centers, and we talk about ultimately limb molding as well as body molding and head molding and so on. And then finally, after all of that, we really then get down to understanding that the development of posture, the development of movement is quite a big context, because it's moving the body around the viscera, but it's also moving the limbs onto the body, and it's moving tone from lying down to then sitting and then to being vertical. So there's a gravity, autonomic, visceral blood pressure perspective to movement and posturing as well. So as we begin to understand this, we revisit the postural reflexes, the development of the vestibular system, the eyes, motions, vestibular-ocular, vestibulospinal, all of these things, which then set us now into a much better understanding for when the concept of retained primitive reflexes come into play. And so, you know, what are they? What does it do? And what are the outcomes of having retained reflexes? And what's the complexity of it? And we go through a variety of things such as, you know, what are the impacts of having this reflex? What are the impacts of having that reflex? How might that mean that we can work osteopathically? Where are we aiming for? What sorts of things are we going to try to do? Or what exercises can we suggest? How do we screen them for primitive reflexes? So we go through quite a bit of that, and then we constantly refer back to the movement is what sets you up for your ongoing intellectual and language development, ultimately then your emotional and social. So this PILES dynamic, P-I-L-E-S, places the development of language then with movement. And so when you then put movement and language together then with interaction, you get the issues of sense of self and sense of others. And so there's a whole issues of the emotional dynamics coming along based on movement and experiencing and language development. And so, yes, obviously there's the brain-gut axis and the microbiome linking into all of this sensory processing disordering that we then learn how to work our way through. But we learn that, you know, there is this phased dynamic, and that you have to, your later development depends on the complexity of your later development and the efficiency of it all, if you like, and the competence of it all depends on this underlying early dynamic. So we certainly go through all sorts of things to do with that developmental dynamic, and we introduce the cerebellum as the font of all wisdom for language, which might be a new idea for you. And we talk about, you know, if you've got movement milestones, motor milestones like walking, which language milestones and which activity and comprehension cognitive milestones, such as, you know, being able to point to clothes or label things, or how many words in your sentence should you have. We go through a lot of these sort of linking language and movement dynamics. But we don't forget about the expressions that all of this then has on thought, ordered, vision, interpretation, concepts of relationship, and emotions and dynamics. And so there's all sorts of things based on that. And of course, we can't at that point then, as we're 2/3 the way through the paediatric series now, we can't then miss the fact that receptive and expressive language it is again a complex dynamic. So you have to hear a thing, so you have to tip your head to hear, you have to get the sound in, so it has to get past the ear and the middle ear and all of that. It has to get in there, and in this crowded network space of sensory processing, sense has to be made of it, and your prior history and experiences and the orderliness of those will help the ability to process ongoingly new information. And then you have to decide what it means, having received it. You have to decide what it means, and then you have to think of what it is that you then want to say. So you want to then try to form a word, so you've got a motor patterning. Then you try the word expressive language, and the sound that you make and the sensory experiences as you try to form that word and produce some form of phonation or vocalization, and you hear again yourself speak it. There are all sorts of things concerned with the development of language and cognition and so on. So we go through a whole bunch of stuff with that, and of course that we then continue to work with sort of concepts for you know, glue ear and otitis and so on. But we introduce the tongue, we introduce the other muscles, we introduce all of this sort of stuff. And then gradually, as one continues to develop, it's all about, as a child gets older, body image, body awareness, interoception, but emotions and interpersonal dynamics. And we understand the link between body imaging and then can you actually impact somebody's interoception and body perception and body imaging by hands-on care. So we talk about some dynamics of, you know, in the context of, for example, older children and adolescents with body image and mental and emotional dynamics. How does body work fit into that? We also then talk about as you grow, you need different things, you need more nutrition, you have a different physiology, a different metabolism and so on. And so that can place a strain. And we remind you that interoception is that if you're nutritionally not quite right, that's destabilizing to your state and your autonomic regulation, which will lead to emotional and cognitive disruptions, if you like. So even just nutrition can set you off. And we talk about this whole dynamic as well with exposure, with immunity, and how to fit all of those things in. And we finally then come back with respect to circulation and hormones and bones. And bones are an organ. And what do bones do? And when osteopaths work on bones, we aren't actually just doing something physical, we're doing something physiological. So we do talk about that. And then, of course, you know, in the visceral context, we can talk about different types of potential visceral problems, such as functional gastrointestinal disorders, maybe constipation. We talk about abdominal migraines. We talk about you know, protocols that you can consider and so on. And we look obviously at posture, and we look at respiration. We look at lung functions and lung flow, and obviously we look at upper respiratory tract airflows, tonsils, adenoids, mouth breathing, how that impacts on sleep, and all these sorts of things. And we keep at this stage now then revisiting back as we're 3/4 of the way through the pediatric series. We then can now see things like ears, eustachian tubes, throats, and so on in a new light. We can bring further understanding to the airway dilators, to the airflow, to the sleep regulation, also even right back down to the suck, swallow, breathe coordination. And we talk about things that you can do with you know, throats and cervical fascias, and how you do muscular retraining, and how you work orally as well as you know, cranially, but you have to work bodily and with posture and recoordinating yourself, because if you've been working a certain way for airflow and then you want to remodel that, all of your postural motor coordination has got to be repatterned. So finally, we get to this idea of integrated three-dimensional functioning, and we understand how then, if your body's in the right place, if your physiology is in support of that, then you're going to have more possibilities and more actions. And that sort of almost automatically then leads us on to sports and development and getting achievements and sort of doing things, and actually how ultimately, when it comes down to it, children with sports and experiences and performance is not about literally just their biomechanics. It's about their anxiety, their sense of self, their body image, their levels of physiological arousal. Is it appropriate for the sport stage that they're at, the action that they're trying to perform? And how actually what impacts performance, and what is leading to them becoming injured, what's leading to them feeling awkward about wanting to do sports or avoiding it, or trying too hard at sports and having too much compulsion. And we talk about all of those sorts of stuff, and adolescent mental health, and we talk about, you know, issues of, you know, damage and concussions and so on. But we certainly do come down to the pediatric skeleton. We do talk about overuse injuries. We talk about the impact of immature bones and the overuse of muscle insertion, pulling, and dedicated sports movement, leading to too much stress strain on an immature skeleton. So we certainly talk about that. And we talk about limb disorders and orthopedics, and we talk about various techniques, and whether they're done on the older child or the younger child, we are aiming to give a whole range of things. So look, that is a complete snapshot of the series. There's more to it in the series than that, but anyway, I hope that little bit of a talk through has given you some, you know, information that might be useful for you anyway. And if you want to come to try to obviously look at the course, then just simply go to the caroline-stone.com website. It's got all the instructions there to remind you to make a login. Then if you buy it, you have to make a login on the Stone Education course website, and then you can then be transferred onto the course and you can get going. I'll see you there. Thank you very much.